So we are going to see some of the advanced ECG topics. We will start with this interesting lecture which is called ECG as Poorman's coronary angiogram, especially in acute coronary syndrome. So first of all, we must know what is the difference between a coronary angiogram and an electrocardiogram. Coronary angiogram is a luminogram. It gives you the lumen of a big epicardial coronary artery, whereas the ECG gives you ultimate myocardial perfusion. It tells you whether the myocardial cells are receiving the blood or not. For example, if you imagine a river and the river is supplying the plant through the big canals, and small pathways, ultimately the plant gets water. Coronary angiogram tells you that the river is normal, but ECG tells you whether the plant is getting water or not. That is, the myocardial cell, be it a big artery, small artery, or a capillary or arteriole, wherever the block is, if the cell is not getting the blood supply, ECG will show abnormality. That's why some of the times the patient may have typical angina or a positive treadmill test. Even he can have myocardial infarction, but the coronary angiogram may be completely normal. The problem may not be in the coronary arteries. As I told you yesterday, as I told you in the vascular system, the obstruction may be in the microcirculatory system. So that's why the ECG gives you very ultimate information about the blood supply to the cardiac muscle cell. The additional information you can get from the electrocardiogram apart from the coronary angiogram is the myocardial viability. The ECG tells you whether the myocardium is viable or not. So the coronary angiogram tells you there is a coronary obstruction, and the ECG alone tells you whether the myocardium supplied by this obstructed artery is healthy or scarred. If the myocardium supplied by this obstructed artery is going to be scarred, there is no point in revascularizing this particular obstruction. So that crucial information is given by the electrocardiogram. And the electrocardiogram also gives you some indirect information about the myocardial function. So these are three informations you must get from electrocardiogram, namely the perfusion, viability, and function. So the ECG changes of coronary artery disease are divided into ischemia, injury, and infarction. Ischemia affects the T wave. Injury, the most important segment of electrocardiogram, is ST segment. Injury is always due to acute coronary syndrome. So acute coronary syndromes are going to be manifested in either ST segment elevation or ST segment depression. Then the infarction, a permanent necrosis of the myocardium, going to result in pathological Q wave and the loss of R wave. So these are the three ECG changes of coronary heart disease: ischemia, injury, and infarction. Ischemia affecting the T wave, injury affecting the ST segment, and infarction is going to produce the loss of R wave and the presence of pathological Q waves. Why should we localize? So for example, if you know, it is easy to know that which coronary artery is obstructed, especially when the patient comes with ST segment elevation myocardial infarction. So that's why the localization is going to be useful for when the patient comes with the ST segment elevation. But there are certain exceptions where even there is no ST segment elevation ACS, you can still localize this particular artery is obstructed. So first we must know which artery is obstructed: right coronary artery, left-handed descending artery, or left circumflex artery. Then, having located the particular artery is obstructed, we must know which segment of that particular artery is obstructed. Is it in the proximal segment, in the middle segment, or distal segment? So this will give you ultimately not only the artery which is involved, but it's also where the obstruction is, will give you the prognosis of the patient even before you treat. So this will tell you, the ECG changes will tell you, the localization as well as the artery will tell you whether you have to plan an aggressive management for this patient or a conservative management. So all these crucial informations are there in the electrocardiogram, provided you know the basics of the ECG as well as the basic pathophysiology as well as the ECG changes related to the particular level of obstruction. So first of all, let us learn about how to diagnose ST elevation acute coronary syndrome or ST elevation myocardial infarction. So, ST elevation myocardial infarction is diagnosed by looking at the J point from the PR segment. So, this is a PR segment, and how much the J point is elevated, especially in the heart rate is normal, how much it is elevated from the PR segment. That gives the amount of ST elevation. To diagnose ST elevation MI, in V2 or V3, the ST elevation should be equal to or more than 2.5 millimeter in males less than 40 years. It should be more than 2 millimeter in males more than equal to or more than 2 millimeter in males above 40 years. In all females, V2, V3 must show equal to or more than 1.5 millimeter ST elevation. Whereas in all the other leads, the ST elevation should be equal to or more than 1 millimeter. So, this is the diagnostic criteria to diagnose ST elevation myocardial infarction. So, this ST elevation should be there in two consecutive leads supplied by the same coronary artery. A single lead ST elevation does not indicate there is a ST elevation MI. So, this ST elevation should be there in two consecutive leads supplied by the same artery. For example, right coronary artery should be L2, L3 or L3 AVF and so on. Sometimes we can diagnose the ST elevation MI equivalent if the patient has got a new onset development branch block, but with abnormal repolarization changes. Sometimes posterior wall infarction will present as ST depression in V1 to V3, which indicates there is a posterior ST elevation. So, there are other two ST elevation MI equivalents where there is LBB and there is ST depression, but the classical ST elevation MI is diagnosed with this criteria. So, having known ST elevation myocardial infarction, then the first important thing or the important question to be answered is which coronary is obstructed. For that, we must know the coronary distribution and what territory that particular coronary artery is supplying. We start from the right coronary. The right coronary starts from the right coronary sinus, runs along the right atrioventricular groove and supply the entire inferior wall of the heart. So, it supplies not only the inferior wall of the heart, but also it supplies the right ventricle and also in 60% sinus node and in 90% AV node. So, this is your right coronary artery supplying the inferior wall. As you know, the inferior wall in the electrocardiogram is represented by L2, AVF and L3, and the right ventricle which is supplied by the right coronary artery is represented by V1. So, this is a V1. So, this territory is supplied by the right coronary artery. Whereas left antedescending artery, which is the most important artery, which is coming in anterior interventricular groove. It is running on anterior interventricular groove represented by the leads V2, V3 and V4 is going to supply the anterior wall of the left ventricle as well as the interventricular septum. That is why it is the most crucial artery, because it supplies the bulk of the main ventricle, which is the left ventricle. Whereas the left circumflex artery, which is running on the lateral surface, is going to supply the anterolateral wall of the heart, which is represented by V5 and V6, and also the high left lateral wall of the heart, which is represented by L1 and AVL. So, entire lateral wall is supplied by the left circumflex. So, by looking at the group of leads, you not only know which surface you are looking at, you also know which coronary artery is supplying this surface. So, this is how you must see the ECG to locate the coronary artery. For example, when I look at L1, you must also look at AVL, because L1 and AVL represent high left lateral surface supplied by left circumflex artery. Along with L1 and AVL, you must also look at V5 and V6, which is anterolateral wall, which is supplied by the circumflex. So, all the four leads should be looked together. Then you look at L2, L3 and AVF, which is inferior wall supplied by the right coronary artery. Along with that, you must always look at V1, which is also supplied by the right coronary artery. Then you look at V2, V3 and V4, anterior wall of the left ventricle as well as the interventricular septum, which is supplied by the left antedescending artery. So this is how you must look at the ECG. First look at the high lateral wall, then anterolateral wall, circumflex territory. Then look at the inferior wall and the right ventricle, right coronary artery territory. Then the septal area as well as the anterior wall supplied by the left antedescending artery. So you know that if these particular leads are going to show ST elevation, you know that particular artery is obstructed. As you know, the difference between ST elevation MI and ST non-LC elevation MI is ST elevation MI is most often due to acute total occlusion of a major epicardial coronary artery due to red thrombus, which is rich in fibrin. So when you have a ST elevation MI, it means one of the arteries are totally occluded. It is acute occlusion, and third, it is having a thrombus which is rich in fibrin. That's why it's a red thrombus. That's why in these situations, thrombolysis is indicated, but best therapy will be a primary PCI. Whereas when the patient comes with ST depression or a symmetrical T wave inversion, which represents non-ST elevation ACS, is most often due to critical occlusion of a major coronary artery, not total, critical occlusion of the coronary artery by the white thrombus, which is rich in platelets. That's why you never thrombolyze a patient who comes to you with acute chest pain with a ST depression or a symmetrical T wave inversion. So this is a concept of ST elevation MI and non-ST elevation ACS. Then we must see which coronary artery is obstructed. Then we must look at how much it is obstructed. So this is what I just alluded to. So whenever a patient comes to you with a ST depression, acute chest pain with ST depression, which is a subendocardial injury, which is due to plaque erosion, and a thrombus which is formed is going to critically occlude coronary artery, and this thrombus is rich in platelets. So that's why you never thrombolyze a patient who comes to you with ST segment depression. Whereas whenever the plaque ruptures and the plaque is rupturing, will expose the lipid core to the circulation. Because the lipid core is exposed to the circulation, there will be not only the platelets which gets activated, but also the coagulation system gets activated. Because the platelet and coagulation system get activated, you have a huge thrombus burden when the plaque ruptures, which totally occludes the coronary artery. And at this point in time, this thrombus, because it is rich in fibrin, so you can thrombolyze this patient, and the ECG changes of this acute total occlusion. This is a critical occlusion with white thrombus. This is a total occlusion, and the thrombus is now red because of it's rich in fibrin. These patients will come to you with a subepicardial injury shown by ST segment elevation. So these are the patients who are eligible for thrombolysis or a primary PCI. So having located a particular coronary artery, if the patient has got ST segment depression, he can have a critical occlusion. If he has got ST elevation, he may have a total occlusion. Please remember, the localization of the coronary arteries are applied only when the patient comes to you with the ST elevation, with few exceptions of ST segment depression. But primarily, we apply this localization for patients who are coming with ST elevation MI, total occlusion. So look at the electrocardiogram here. In the electrocardiogram, you can see the patient is coming with acute chest pain, and there is a significant ST segment elevation. So this is a elevation. So it is, we know immediately it is acute total occlusion. So it is also due to red thrombus. All the things immediately know because it's ST elevation. Then you have to localize which coronary artery is obstructed. V2, V3, V4 is LAD territory, L1, AVL, V5 and V6. So all the leads representing the left ventricle are involved here. The septum, anterior wall, the high lateral wall and anterolateral wall. So everything is involved here. So this means probably the patient has got either total occlusion of left antedescending artery and left circumflex, or he may have a occlusion of the left main itself, which will present the injury in both area supplied by the left-hand descending and left circumflex artery. So here we know, because it's a red thrombus, we got to do either primary PCI or thrombolysis. Whereas look at this patient is coming acute chest pain once again. He has got significant SC segment depression. So this becomes a non-ST elevation ACS. So the most important thing is here, you don't thrombolyze this patient. And depending upon the risk of the non-ST elevation MI, if the patient is a high-risk patient like this, where the patient has got multiple huge ST segment depression, he must immediately go for thrombolysis. He has also got AVR and ST elevation here. So this is a very critical occlusion. Then this patient should be going for immediate coronary angiogram. If a patient is low risk, you can treat him medically with heparin, dual antiplatelets and high-dose statins. So now we have located which coronary artery is obstructed. Then we have said, we know whether in acute occlusion, we also know whether it is critical occlusion due to white thrombus or a total occlusion due to red thrombus. That management is completely different for these two methods of obstruction. Then the most important question is, having located a particular coronary artery, I want to know in that particular coronary artery, where is the obstruction, whether it is proximal, mid or distal. So that is the most important question we are going to answer in this lecture. That's why we call this as coronary angiogram from the electrocardiogram. So for locating where a particular coronary artery is obstructed, to locate a coronary artery, we have seen the group of leads. We already know that. But to see in which portion of that particular coronary artery is obstructed, we have to look at two important leads we hardly look at in our day-to-day practice, which are AVR and V1. So these two leads gives you information about the localization of the lesion in a particular coronary artery. Now the question comes, why should we localize? We have to localize because we want to know whether the coronary artery is obstructed proximally or the coronary artery is obstructed distally. So here, what is the problem in a proximal obstruction is, whenever you have a proximal obstruction, be it right coronary artery or a left-handed descending artery or a circumflex artery, two things are going to happen. Because it's a proximal occlusion, all the branches are going to be involved. So you have a very huge myocardium is at risk. When compared to a distal obstruction, where some of the branches would have been escaped, so because of that, some of the myocardium will be spared and some of the myocardium will be involved. Whereas when you have a proximal obstruction, it is going to involve all the branches of the coronary artery subsequently. So a huge myocardium is at risk. One. Second, the proximal left-handed descending artery branches as well as the proximal branches of the right coronary arteries are the ones which supply our conduction system. The right coronary artery supplies a sinoatrial node and atrioventricular node, whereas the proximal branches of left-hand descending artery supplies the bundle branches and vesicles, which are the distal conduction system. So when there is a proximal occlusion, your conduction system is also at a huge risk. They are going to be ischemic or they are going to be infarcted. So this will result in further complication of arrhythmias and conduction disturbances, AV blocks, complete heart block and so on, which will further complicate the picture. That's why it is very, very important from the ECG that the first ECG you are taking. So what we are going to talk about is the first ECG you are taking when the patient comes with acute chest pain. So when the proximal obstruction is there, the huge myocardium is at risk, your conduction system at the risk. So that's why we have to, from the ECG, first ECG you are taking, you must not only know whether it is a particular, whether it is a first ST elevation ACS or non-ST elevation ACS. In ST elevation ACS, which coronary is obstructed? Having seen this particular coronary is obstructed, I want to know where the coronary is obstructed. So this is what I told you. The proximal branches of the LAD is going to supply the conduction system, right coronary node, the SA node and AV node. The left-hand descending artery is going to supply your bundle branches and vesicles. So this is a diagram we will use to locate a particular coronary artery obstruction. So this is your left-handed descending artery. The first two proximal branches are first septal branch, which we call them as S1, and first diagonal branch, which we call them as D1. So any obstruction proximal to these two branches are called the proximal left-handed descending artery lesions. So the first proximal left-hand descending artery lesions are very, very critical, very dangerous because of the 2 points I have told you. One, we have a huge myocardium is at risk. Second, the proximal branches, as you know, they are supplying your conduction system of the heart. That's why it is very, very important to locate whether I have a proximal LAD lesion. So whenever you have a proximal LAD lesion, proximal to the first septal branch and first diagonal branch, the injury which is happening because of a total occlusion will be primarily involving the basal segments as well as the apical segments. But the basal segments like basal septal region and basal high left lateral region are involved more than the apical regions. Because of that, the basal regions are more involved and they are more injured. Your ST segment vector or ST segment direction is likely to go from the apex to the base. That means it is going to travel from inferior surface to the superior surface because my base of the heart is involved, basal septum as well as the basal high lateral wall. Because my injury vector is going to go away from inferior to superior, my inferior leads will show ST segment depression. So whenever ST segment depression is there in the presence of anterior wall infarction or anterior ST elevation, you must imagine my basal areas are involved. So they not only directed upwards, between these two, the basal septal region as well as the high lateral left high lateral region, the basal septum is going to be the more involved than the high left lateral wall. So because of that, the injury vector not only travels upwards, it also travels towards the right side. So because it is traveling towards the right side, your V1, which is the right side lead, and the AVR, which is once again the right side lead, will show ST elevation. Because this vector is directing towards the right side, your anterolateral leads like V5 and V6 will actually show ST segment depression. You will have ST elevation V1 to V4, ST elevation ACS in V1, ST elevation should be more than 2.5 millimeter to diagnose the proximal LAD lesion, and your AVR also will show elevation. In a proximal LAD lesion, V1 will show more elevation than AVR, but both the leads will show ST elevation with reciprocal ST segment depression in inferior leads. So the concept to be understood here is in a proximal LAD lesion, because of the basal septum is more involved, base is more involved more than the apex. Between these two bases, the basal septum is more involved. My injury vector is directed superior and towards right. It is directed superior and towards right. So now we look at the electrocardiogram here. I have ST elevation here in septal leads, V2, V3, V4. So I must immediately, I should not only see this anterior ST elevation, my eyes immediately will go to the inferior leads immediately. The inferior leads are showing ST segment depression, which means my injury vector is going superiorly. So having decided my injury vector is going superiorly, I must look at the right side leads, AVR and V1. The V1 shows ST segment elevation more than 2.5 millimeter. AVR is also showing ST elevation. That means I have understood in this ECG, what is happened is the injury vector is dying superior and towards right side. So this is a very proximal LAD lesion and this is a very high risk infarct. And this patient, if possible and affordable, this patient should immediately go for early coronary angiogram and primary PCI. Because of the two risks I told you, very huge myocardium is at risk and also the conduction system is at risk. So in a proximal LAD, which is proximal to septal branch and the diagonal branch, the injury vector travels superior and towards right. So please remember, when a proximal LAD lesion has happened, the first septal is involved. The first septal is the one which supplies the right bundle branch block. So in antral infarction, you have acute onset of right bundle branch block. It also means the patient has the proximal LAD lesion. So acute right bundle branch block in the presence of antral MI once again indicates there is a proximal occlusion of left hand descending artery. Here you can see the terminal delayed positivity in V1, QRS is widened. So this patient has got antral infarction with the right bundle branch block. So because the right bundle is involved, so I know the septal branch is involved, then the obstruction is likely to be proximal to S1, which is a proximal LAD. So there are two signs of proximal LAD occlusion. One is ST elevation and the superior and rightward deviation of ST elevation, whereas acute right bundle branch block. So very proximal LAD lesion will have what are the changes? Signs of basal septal involvement. ST elevation in AVR. ST elevation V1 is going to be more than 2.5 millimeter. ST elevation in V1 is going to be more than AVR. It could be a right bundle branch block because the injury vector is going to come towards right, away from the left side leads. ST depression in V5, V6 may be there. So these are the important ECG signs of diagnosing the most dangerous ECG of a very proximal LAD lesion. So having decided that, having seen that the proximal LAD lesion will produce these changes, we come to a lesion which is a mid LAD lesion where it is beyond the first septal branch but proximal to first diagonal branch. So what will be the ECG changes here? What will be the ST vector here? Now I have a lesion beyond first septal but proximal to diagonal, first diagonal. The first diagonal is the one which supplies the high left lateral wall. The first septal is the one which supplies the basal septal wall. Because the first septal is no longer involved, the basal septum is no longer involved now. It is only the basal left lateral wall which is involved. Because the basal region is involved, once again the vector is likely to go towards base. It is going to go away from inferior leads. So in this lesion also, your inferior leads will show ST segment depression, telling you that the ST vector is going superiorly. But contrast to the previous ECGs where there was a proximal LAD occlusion, the LAD occlusion beyond the first septal branch will predominantly involve the high left lateral wall, high left lateral basal wall of the left ventricle. So now the injury vector is directed up and towards left because no longer I have the basal septal involvement. So because it is going up and left, I know the basal septum has escaped and it is predominantly involvement of the basal left lateral wall. That means my lesion is beyond first septal branch but proximal to D1 branch. So you can see it here, all because the injury vector is going upwards towards the basal region, inferior leads will show reciprocal ST depression, but no longer my right sided leads AVR and V1 are showing ST elevation. Whereas my lateral leads V5, V6 and L1 are going to show ST segment elevation because now injury vector is directed towards left side. So that's why these left lateral leads and high lateral leads are going to show ST elevation. We look at the ECG now and we concentrate on the ST segment elevation V2, V3, V4. I told you immediately look at inferior leads. My inferior leads are showing significant ST segment depression. That means my injury vector is going superiorly. Then I must look the right sided leads and the left sided leads. My right sided leads are not showing significant ST elevation, AVR and V1. Whereas my left sided leads like V5, V6 and AVL are showing ST segment elevation, means my injury vector is directed superior and towards left. So this is likely to have the middle lesion beyond first septal branch but proximal to diagonal branch. So this is a mid LAD occlusion. So now we have seen the occlusion here. Now we are going to see what will be the ECG change or the injury vector movement in a patient who has got a distal LAD lesion which is after first diagonal branch and after first septal branch. So what will be the lesion here and what will be the injury vector's direction here in distal LAD lesion? Because the first septal branch and also the first diagonal branch are spared and the lesion is beyond these two branches, no longer my basal septum is going to be, or basal septum or basal lateral wall is going to be involved. So my base is not involved. Because my base is not involved, no longer my injury vector will travel superiorly. Because my injury vector is not traveling superiorly, I will not have any reciprocal changes in inferior leads. Whereas I have changes in the anterior ST segment elevation, but I will not have the ST segment depression, especially in L2, L3 AVF. So ST vector is not superior in a distal lesion. Then the ST, what is the behavior of ST segment in inferior leads is going to be decided by whether your LAD is short or your LAD is long. So that's what it is going to decide. So either in a distal lesion, there may not be any ST elevation or ST depression in inferior leads, or there may be contrast to expectations. There may be even ST segment elevation in inferior leads, especially when the left-hand descending artery is long. So look at this ECG here. I have a ST segment elevation anterior leads. So immediately I look at the inferior leads. My inferior leads are not showing L2, L3 and AVF are not showing any ST segment change. The ST is normal here. That means my ST vector is not going superiorly. So it is not going superiorly. My ST vector is normal inferior leads. I know this is a distal LAD lesion, and this distal LAD lesion and this LAD is likely to be short when there is no ST segment changes in inferior leads. The distal LAD and short LAD. So this is the ECG. You may have little bit better prognosis because it's a distal lesion and the distal LAD is not supplying a huge myocardium. So you can see the inferior leads are not showing ST segment depression. So this is what happens when the LAD is short. Let us imagine I have a distal lesion, but in distal lesion I have a long LAD which also supply winding round the apex and also supply some amount of inferior wall. So in this lesion, what will happen is my injury vector is now directed inferiorly because this basal, this apical segments are involved and the inferior wall is involved because of a very long LAD which is wrapping around the apex. This is called wrap around LAD, a very long LAD when there is a distal lesion. Because my inferior wall is also involved, in addition to ST elevation anterior chest leads, I may have also ST elevation in my inferior leads. So in the presence of anterior ST segment elevation, if you have some amount of ST segment elevation in inferior leads, it is not a associated right coronary lesion. It is more likely that the distal LAD lesion is because of very long LAD which is also wrapping around the apex. This is called wrap around LAD, where you have ST elevation in inferior leads. Whereas in a proximal or mid lesion, because of the ST vector is going superiorly, you have ST segment depression in inferior leads. So what gives you very crucial information about the location of the inferior lead of the left-hand descending artery is the inferior leads. If I have ST segment depression, I am dealing with proximal or mid LAD lesion. If I don't have ST depression or ST elevation, I have a distal LAD with a short LAD. For example, this distal LAD is short and is not going around the apex, my ST vector will be normal in inferior leads. Whereas if the inferior leads are showing ST elevation, I have a distal lesion, but the LAD is long and it's also supplying the inferior wall. So it is ST elevation L2, L3, AVF. So in this way, we can actually locate not only the level of obstruction in that particular coronary artery, We can also predict that particular coronary artery is very long and supplying a large area of myocardium. So now look at this electrocardiogram. I have ST segment elevation in anterior chest leads. So immediately I look at the inferior leads. To your surprise, you have found there is ST elevation in L2, some elevation in L3 and some elevation in AVF. So you can see that ST segment elevation in L2. So that means the injury vector is coming inferiorly. Because why it's coming inferiorly? Because my LAD is also supplying, wrapping around the apex and also supplying some amount of inferior wall. So whenever there is ST elevation, you must suspect a long LAD, which is wrapping around the apex. So let us sum up the things in anterwall infarction. Whenever ST elevation V1 to V4, immediately look at the inferior leads. If there is an inferior ST segment depression is there, you are dealing with either proximal or mid-LAD lesion. Then to decide between mid-LAD or a proximal lesion, look at two leads, AVR and V1. So in the presence of inferior ST segment depression, you have ST elevation in lead AVR and V1. V1 ST elevation is more than 2.5 and the AVR ST elevation is there. You are dealing with a proximal LAD, which is proximal to first septal branch and first diagonal branch. Whereas you have inferior ST segment depression, but I don't have ST elevation in L1 AVL, but I have ST elevation in left lateral leads. That means your basal lateral wall is involved. So the septum is not involved. That means the injury vector is directed superior and towards left, which will result in mid-LAD lesion and distal to first septal branch, but proximal to diagonal branch. So if I don't have any inferior ST segment change, neither depression nor elevation, it is a distal LAD lesion, which is a short LAD, which is not winding around the apex. No ST segment change. Whereas in contrast to this ST segment depression, in the presence of anterior ST elevation, if I have inferior ST elevation, it means a wraparound left-handed descending artery lesion, and it is a very long LAD. Once again, although it is a distal lesion, this will have a little worse prognosis because a lesion is happening in a distal LAD, which is also supplying a huge area of myocardium. So what gives you the crucial information is not the ST elevation in anterior leads. It is the other leads which are giving you mutual information. The inferior leads as well as leads like AVR and V1 will give you crucial information regarding the location of a particular coronary artery. So if you have acute right bundle branch block, it also indicates a proximal LAD lesion in addition to ST elevation, AVR and V1. Now, having said that these are the ECG changes which will predict a particular site of coronary artery occlusion, what is the scientific evidence and what is the sensitivity and specificity of these changes to predict that particular occlusion in that particular site? So when you have ST segment elevation in V2, V3, V4, if you have ST segment elevation in V1 more than 2.5 millimeter or acute onset of right bundle branch block, these two ECG signs can predict a proximal left-handed descending artery, very high specificity, almost 100%, but very low sensitivity, and your positive predictive value is almost 100%. In contrast to that, if you have ST segment depression in more than 1 millimeter in inferior leads without ST segment elevation in B1, which will say the diagnosing proximal left coronary artery is once again have got good specificity but low sensitivity, only inferior ST segment depression. Whereas if you don't have ST segment depression or you have ST segment elevation in inferior leads, predicting distal left coronary artery have got reasonable sensitivity and specificity. So this is the scientific evidence and the basis of locating LAD.